Good. Okay. Well, welcome to everybody. And thank you, as the secretary said, thank you so much to our sponsors tonight, which is AbbVie. And it's a slightly misleading title. I apologize for that. Treatment adherence in complicated HIV patients, but really focusing on adolescents. And these are my disclosures. And the thing is that in order to look at adherence in adolescents, you have to understand the adolescent patient. It's not a question of just do this, this, and this. Okay, so adolescents, it's the whole package. It's not just adherence. Okay, and the whole package is there. If you don't get the whole package right, you're not going to get adherence. So I'm going to focus really I'm sorry that it's misleading. I'm going to focus really on adolescents with HIV, but obviously our goal is to get them to take the treatment. You have to understand adolescents and HIV in adolescents to understand adherence in adolescents. Both very, very difficult, but that doesn't mean we're not going to try. Let's try and see where we go. So what is the nature of the problem? You can see we are struggling. Okay, this is 2017 data, but you can see, and I don't think it's improved very much on this sort of, whereas your adult groups we're getting up to 73% viral suppression. Your adolescents with 47.7 and 15, obviously, and 51%. Obviously, the first group includes children, and the older group includes adults. Although I must tell you that today, to me, although according to WHO, the definition of adolescent goes up to 20 years, to me, in terms of behavior and difficulty in managing patients, adolescent goes up to 25 years. Okay, and that's from seeing my cohort of patients grow literally from babies to now the young adults, and I'm still having adolescent issues with them well into their 20s. Okay, so don't relax when they hit 20. You've still got a way to go. Okay, so there's two kinds of adolescents that we're going to deal with, and we want to see, does it make a difference in terms of adherence? Which ones you're dealing with? So the one, first of all, you've got your horizontally acquired patients who obviously are sexually active and are picking up HIV. Remember, in that group, there will be patients who are abused as well, right? So it's very important. It's not always consensual, and that also can have major impact on the patient, on adherence, on their psychological well-being. So very important to remember that as well. So how do we distinguish the two? So let's look at the horizontally acquired. So they've grown fairly normally until they picked up their HIV. So usually of normal height and normal development. CD4 often normal. Why? Because they've picked up HIV fairly recently. They are either naive or less experienced because they've only been on treatment for a short period of time. They're relatively easy to suppress. Okay, well, they're relatively easy. Why? Because they're virtually all going to be on first line, so it should be easier. By definition, they are sexually active, although, as I mentioned, they may have been abused. Pill fatigue is less likely because they've been on treatment for a shorter period of time, but yet they still have adherence problems because they are adolescents. Let's look at the virtually acquired group. They are usually short. Okay, not all my patients are short, but a lot of them are. So their weights may be fairly normal, but in terms of height, they are stunted. Puberty may be delayed, especially those who went through puberty weren't on treatment yet. Once they're on treatment, usually puberty is not delayed. CD4, if they're not on treatment, will be low, or if they are failing the treatment. Often they are highly antiretroviral experienced. They may have multi-resistant virus. And of course, we see the whole spectrum of sexual activity, from sexually active to not sexually active. And often it may be, both ends may be because of their HIV status. I've had patients who are scared to become sexually active because of their HIV status. And obviously, we see the opposite extreme as well. Pill fatigue is very likely. And once again, they have got adherence issues. So there are differences. It's not always easy to tell them apart. If they're short, it's often a pointer to the fact that they're virtually acquired, but not always. But the bottom line with both of them, you get adherence problems. So this is really the rest of this talk, which I'm going to go through with you. I'm not going to go through it now. And we're going to look at all these things that we need to do, because every single one of them is important in terms of getting patients to adhere and to suppress their viral load. By the way, as we go, please type questions in the Q&A. Don't wait till the end. And Lesecha will answer some of them, and I will answer the rest. Even some of the ones that Lesecha is going to answer, if there are any interesting ones. If there are any interesting ones, we can certainly come back to it at the end as well. Okay, so how do you speak to teenagers? You know, it's probably very similar to how you should speak to adults, but the problem is, if you don't get it right with teenagers, you just don't get it right. Okay, first of all, you don't want to have any disturbances. When I was in private practice in Benoni a few years ago, now I've got a smaller private practice, it's not such a big deal, but in those days, I used to have a very concerned nursing sister who used to work with me, and she used to basically run my patients for me, you know, and so she was it was very important for her to know what was going on. So when I was busy with the patient, she was in and out, coming in, arranging the files, looking, but basically just to see what's going on, which is fine. I didn't mind that. But when you get to a time when you know, you need confidentiality, you need not to be disturbed, what do you do in that situation? So I just had a little sign on the door, and I turned it back to the door most of the time, but when I was busy counseling a patient, I would turn around and say, counseling in process, please don't disturb. So she knew not to come in just at that time. And the rest of the time she felt free to come in. So simple thing like that you can do. The next thing is that it's very important in terms of developing a relationship with a child and a teenager, not to let them think you are talking behind their back. Okay? And it's people come in and hush, 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 and we kick out the child, and of course they know you're talking about them, right? That's not what you want. Okay, I talk as far as possible in front of the child, and if I need to speak to the child alone, that's the greatest thing, because then you just kick out the parents, you know, and that's, you know, child gives us a big smile. They say, excuse me, to the parents, excuse me, I need to talk to your child. Please go outside. So what do you do if you do need to speak to the parents alone? So you have to sort of think out the box, think ahead. If you do think you need to do that, well, you can do a telephone call before. You can arrange you know, these days you've got Zoom, you've got WhatsApp calls. You can do a little call before, discuss the issues before the child comes in. If it's something that comes up in the middle of your consultation and you need to discuss it with the parents, well, you know, then you use a trick. I know what a colleague of mine, Dr. Turner, does is she says, you know, she'll find an excuse to go outside, and speak to say, I've just got to go speak to somebody else. Okay, go outside, and then ask that somebody else to, for example, call the parents out. So we just need to speak to you, and so somebody else is calling the parents out, and then she goes and grabs the parents, chats to them, they go back, and then she goes back, and child doesn't realize that she's spoken to them. Something like that. You can just think out the box and different ways of doing it. Okay, the child needs to know that whatever you discuss is going to be confidential, and you will not tell the parents, even if you think it's important, unless the child gives permission. Obviously, the child tells you he's a gangster and it's about to rob a bank, and you know what I'm saying, okay, that's a different story. But even then, you should ask permission to tell the parents. And you say, look, is it okay if I discuss with the parents? I think it's very important what you're saying to me, and I think it's important that we try and deal with it. And the only way we can deal with it is if your parents are aware of it. Is it okay if I discuss with your parents? And if you get that consent, then you can. But otherwise, the child needs to know that you will not discuss anything. Otherwise, they will not open up to you. You want to always make eye contact, and you want to remove the physical barriers. And we all say, yes, remove the barriers, but you don't realize that what is one of the commonest barriers that we have. Okay, and now we pretend we're hanging from the light from the ceiling and looking down onto the consulting room. Okay, and you can see at the bottom is the healthcare worker, and on the top on the right is the parent, and on the left, or on our left, is the child. Okay, and you can see there's this big red barrier. There is a desk, which is a barrier, physical barrier. There's also a laptop there as well, between us and the patient. So what do you do when you have to counsel a teenager and you need to get rid of that barrier? So this is what I do, and it works quite well. I move my chair to the side, I move the child's chair to the side, and we can speak face to face. And of course, the parent can then turn their chair and they can watch what's going on. And that works pretty effectively, so you don't have that barrier of the desk between you. Okay, very important to speak on their level, but don't talk down to them. And this last point, very important. Okay, your discussions with them must be non-threatening. All right, if a child feels threatened, they will respond in two, or a teenager, they'll respond in one of two ways. Either they will clam up, which we often see with these teenagers, they just sulk and don't talk, or they will lie. Okay, so if you ask him if they're taking the treatment and they feel threatened by that, okay, because they think you're going to shout at them, they will either say, yes, I'm taking my treatment, or they will just clam up and not say anything. So, but if the child feels non-threatened, okay, they will tell you the truth. We all say that teenagers lie and adults lie. Yes, but they're all lying for constructive purposes, because they think that they're going to get into trouble if they tell the truth, and they tell us what they think we want to hear. So it's very important that must be non-threatening. Okay. So that's how you talk to teenagers. These are things I've picked up over the years. I've consulted with people in the know, psychologists and social workers, and they say it's pretty much on the mark. Okay, so how do we get teenagers to take their treatment? So the first thing you want to do is you want to simplify. Okay, teenagers can't deal with too much. They can't deal with too much tablets. They can't deal with too many times a day. You've got to simplify. So how do we do that? Once daily dosing. You know, it's all well, the adults all taking one tablet a day. Okay, but pediatrics and some second-line patients on twice daily, and they just can't cope with it. It doesn't work. Right? The problem with morning doses, and it doesn't seem to be an issue with adults, because some of the adult guys, I've said to them, morning is not a good time for taking medicine. They say, what do you mean? There's nothing wrong with morning. Okay, but so maybe it's different with teenagers. But the problem with a teenager is that by the time you waken them up for school, right, which admittedly takes a long time, they're already late for school. They throw on their clothes. There's hardly time for breakfast. They'll maybe grab something on the go, and of course, medication gets forgotten completely. Morning is a disaster in terms of taking treatment. So you want to have treatment taken once a day only. Okay, but unfortunately, our regimens are often twice a day. So we need to look at that. Okay. So let's look at this poll. But having said that, I just want to mention before I do the poll is, yes, vast majority of patients prefer nighttime dosing. But I've had, I think, 5 kids, teenagers, who've all said to me, I can't do nighttime, I only do morning. And the strange thing is, all the same reason. They play soccer. I don't know why, but they play soccer. And what happens is, when they play soccer, is they go straight from school to soccer. They come over 10 o'clock at night. They're totally exhausted. They fall asleep. They don't take their medicine. I don't even think they even eat. Wake up the next morning and they've forgotten their medicine. And so it's strange that just of my cohort of patients seems to be that the soccer is an issue. There may be other reasons, of course, but it seems to be, in my practice, that seems to be. Okay, so in those patients, of course, then you would do morning dosing. So you need to actually interrogate and find out exactly what would suit them. Right, let's do the first poll. Which of these patients, so we said you want to do once daily. Which of these ARVs can be given once daily? It's multiple choice.
Interesting.
Very interesting. That's why these polls are always very useful.
Yep.
Just one thing about the polls, they are completely anonymous. Nobody knows what you're answering. So feel free to answer. Preferably not guess, but feel free to answer. Okay, I think we should probably end it there. Let's share it with everybody. Okay, so most people said 3TC, very good. Okay, Abacava, almost 60% said Abacava, 12% said rilpivirine, 30% said lopinavir, Adzenova 23%, darunavir 55%, but it's not reflected there. It's interesting. Okay, 22%. Okay, all right. So the only one that is wrong is AZT. AZT can only be given twice daily. And it's very important, and it's a big problem because in our second line regimen, certainly up till now, it's been AZT, 3TC, lopinavir, ritonavir, and we'll get to lopinavir, which can be given once daily, but the AZT can't. And so you're stuck with a twice daily regimen, which is very bad from an adherence point of view. But all the rest can be given once daily. 3TC definitely, Abacava definitely, rilpivirine is only once daily, it's 1 tablet a day. Lopinavir, although in our guidelines it says you can give it you give it twice daily. We'll get to in the next slide. I think the package insert does say you can give it once daily. We'll discuss that. Atazanavir is a once daily protease inhibitor, and darunavir we'll talk about now as well. In certain situations, can be given once daily as well. All right, so let's go through that in detail. Let me just get rid of the poll. Okay. So lopinavir can be given if it's PI naive patients, and the packaging says in fact less than 3 PI mutations. I'll show you that now. Yeah, okay. I might as well show you now. This is from the package insert. It says lopinavir can be given as a once daily or twice daily dosing regimen in patients with less than 3 lopinavir mutations. So we don't always know if they've got less than 3 mutations, but certainly if they're naive to the protease inhibitors, they change to second line, they've never been on a protease inhibitor before, you know they've got less than 3 mutations, so you can give it once daily in that situation. If there's more than 3, then you've got to give it twice daily. And these are the mutations they mentioned here. You're welcome to look at them, but certainly, I mean, if there's lopinavir mutations and there's resistance to lopinavir, definitely I would, not give it once daily, and probably, in our setting, if there is PR resistance, those patients would then go on to third line anyway. Okay, also in combinations with the anti-epileptics, carbamazepine, phenobarbital, phenytoin, you shouldn't give it once daily. With the efavirenz, the viropirin, and alfenavir, shouldn't, and in pregnant women, you also shouldn't give it once daily. But otherwise, you can give it once daily. I must just tell you that in some of the studies that have looked at once daily, and in my personal experience as well, patients who start with once daily lopinavir all vomit. They all vomit. But I've found if you start with twice daily for a week to get the liver to start metabolizing it, then you can quite happily switch to once daily without a problem. So we give it twice daily for a first week, and then you change. If they're already on a PI, if they're on lopinavir twice daily, and then you switch to once daily, well, then you just switch straight to once daily. Okay. Right. Atazanavir, we said, is a once daily drug. Darunavir, if there are no darunavir mutations, in other words, if darunavir is being used as a second line drug, or even if it's third line, as we see in our third line committee, but it's susceptible to darunavir, there's no darunavir mutations that can be given once daily, and then will be a dose of 800 plus 100 milligrams of ritonavir. If there are darunavir mutations, the patients on third line would then get a twice daily dose of 600 milligrams of darunavir and 100 milligrams of ritonavir. Okay, but all of those drugs otherwise, including tenofovir, dolutegravir, can be given once daily. So you can put together a once daily regimen pretty easily. Okay, so we said once daily dosing. Fixed dose combinations, also very important. You don't want to have separate drugs. Of course, the adults have all got TLD. A lot of our teenagers can go on to TLD. But in some situations, especially second line, you may not have fixed dose combinations, but you've got a backup of 3TC, AZT, 3TC, that's twice daily, the Sanofi, FTC, TLD, the Lopinavir is a fixed dose combination. Atazanavir also comes in a fixed dose combination of 300 milligrams of Atazanavir, 100 milligrams of ritonavir. The ritonavir also comes, if it's given the once daily, the 800, 100, is a fixed dose combination of 400 milligrams of darunavir, 50 milligrams of ritonavir. So together, if you give two together, you're going to give 800, 100. Also reduces your pill burden and improves adherence. And of course, you've got the tenofovir, FTC, rilpivirine, TAF FTC, which is not yet available, TAF FTC dolutegravir, and TAF 3TC dolutegravir, which hopefully will be available in the next couple of months, but they're not yet available, but also fixed dose combinations. So we have what to choose for. Reduce your pill burden with these adolescent patients. Okay. We want to reduce the number of tablets to a minimum. So we've spoken about once daily dosing, fixed dose combination, reducing, but that's not all they're on. These patients are on other drugs as well. You want to reduce those as well. For example, cotrimoxazole. It's not necessary. The patient's got a CD4 above 200 and they're well controlled. You can drop the cotrimoxazole. How often do I see patients who are still on cotrimoxazole? It's just an unnecessary extra pill adding to the pill burden. Okay. Multivitamins. Yes, there's studies showing that in sick kids, when you're starting treatment, they are on a multivitamin, especially with a level of vitamin A above 3,000 units. Yes, it does reduce the incidence of diarrhea. But once that ARV is in control, you don't need multivitamins. It's just an extra tablet they're taking. And especially in the dolutegravir era, where you can't give the multivitamins with the minerals together with dolutegravir because it reduces the absorption. So there you've got an issue because you've got to give the TLD, for example, at nighttime, and now you've got to give the multivitamins in the morning. So you're giving an unnecessary drug second time of the day. So now a BD regimen, which is what we're trying to avoid in the first place. So get rid of it. Get rid of all the unnecessary drugs. You just want a bare minimum in adolescents. It's hard enough to get them to take the bare minimum. Don't give them extras. I had one patient who was on something like 20 different vitamins. And I said to you, know what? This child is going to get pill fatigue from all the drugs that he doesn't need, and he will end up not taking the drug that he actually doesn't. So very, very important. Reduce the number of tablets, not only ARVs. What does it mean, closed captioning?
I think it's the automatic transcription. Let me manage. It's okay.
All right, thanks. Okay, the next thing is you want to fit the meds into the teenager's lifestyle. Okay, it's much easier to fit the medicines into the child's lifestyle than to fit the child into the medicine's lifestyle. You know, at our clinics, we try and tell them exactly, you have to take it exactly at this time and this time. You know, it's got to be, if it's twice daily, 7 and 7. I mean, that's drummed into patients. I mean, 7 o'clock, often the patient's sitting on a taxi, right? On the way to school, or on their way to work, and now they expect to take their medicine. You know, everyone's watching you. You've got to look around, make sure no one's watching you. Take out your medicine, take out some water. You know, quickly take it when they're not watching. It's not going to happen. Okay, they can take it before that, and it's not necessary to take exactly. We'll come to that exactly 12 hours apart. That's my next point. There doesn't have to be exactly 12 hourly or 24 hourly on the dot, but also it's got to fit into their lifestyle. But to do that, you got to find out what is their lifestyle. We know in adults, you know, patient drinks on the weekends, right? You've got to find that out because they can take the treatment before they go drinking. So that at 8 o'clock when they normally take it at night time, they're going to be drunk. They're not going to take it. They can take it earlier. Rather take it earlier or later if it's not the right time, but take it. Okay. But so you've got to find out what their lifestyle is. I had one patient a few years ago who was failing a treatment. And I said to her, look, you know, when are you taking your treatment? She says at night time. Okay. So I said, well, you know, why is it not happening? She says, well, I'm very often I'm out partying. And, you know, I forget to take it. So I said, okay, well, what time do you come home? And sometimes 12, sometimes 1, sometimes 2. So I said, who lets you into the house? She says, her mother. I said, right. So now, when you come home from your party, no matter what time, as soon as you come home, your mother grabs you and you do the treatment together. Okay, so you've got to fit the medicine into their lifestyle. Find out what they like. I spoke about this, kids who are playing soccer. They're playing soccer and come home exhausted at night time. It's not going to work to give them treatment at night time, and they're not going to take it. You have to find out when is a good time to take treatment. And they generally should be able to choose which would work well with them. Remember, it's not cast in stone. If it doesn't work, if the nighttime doesn't work, they can change to the morning, they can change back. Can't do it all the time, sometimes night, sometimes morning, but certainly they can make a decision. That's not working. Let's try something else until you find something that's going to work for you. As we said, twice daily, once daily is not exactly on time. It used to be in the old days, yes. Okay, in the old days, used to be the drugs had a very short half-life, didn't last long, had to be given exactly on time, but not with the drugs we have today. They last long enough. You've got that flexibility to a good couple of hours before or after the dosage time is not a problem. Okay, and the next thing, there's lots of, this talk is really, it's a synthesis of my experiences with adolescents over the years. It's not supposed to be I've been treating them for 25 years. I've picked up some tips on the way. It's not supposed to be, I'm not covering every single actual, discussion on adolescence. But if you look in all the documents, they will give you a whole lot of different things. And Dr. Julia is going to give a talk on adolescence. No, sorry, on adherence, where she will go through all of these. So this is maybe the wrong way around. She should have spoken first of general adherence, and I would have spoken to the topic of adolescence. But she's away this week, so we'll give a talk some other time. But I've discovered that, of all the different modalities of getting teenagers to take the treatment, in my experience, the only one that works is supervision. Okay, the adolescent body is well developed, right? Yet the brain takes a while to develop, in simplistic terms. Obviously, speaking as a psychologist, they'll go into more detail. I'm not a psychologist. And at some stage, teenagers will have adherence issues. That's the bottom line. I had one patient, she was such a sweet child, and I've spoken about before, don't worry, but we'll get into the habit of taking treatment, because when you become a teenager, you'll struggle. She comes to see me, she says, "Doctor," I said, "Yes." She says, "You see, you were wrong." I say, "What do you mean?" She says, "I'm 30 now and I'm still taking my treatment." I said, well, long may it last. Okay, because it doesn't always last. But yes, so the only thing I've discovered is that you need supervision. Now, I've had this discussion with my psychosocial colleagues, where you've got the issue of you don't want to disempower the child. Okay, so you can't disempower the child by supervising their treatment. Okay, you must let them do it on their own. The problem is, you let them do it on their own, especially with our older regimens. By the time you find out there's a problem, the regimen is gone. With the newer regimens today, maybe, it might still be okay, but you don't want to end up with them failing, especially for long periods of time, and then discover that, they're not taking their treatment properly because they're adolescents, and at the end of the day, you don't want to end up with resistance. So this is the only thing that I have discovered that works, and that is supervision. So how do you go about it? First of all, you want to choose a treatment buddy. Get buy-in as far as possible. So you get them to choose a treatment buddy. Right? They can choose whoever they want. I had one patient who was failing a treatment, and I said to her, tell me something. We discussed, we were honest, it's non-threatening. So she was telling me she wasn't taking treatment. So I said, tell me something. Does your treatment buddy know you're not taking your treatment? She says, yes. So I said, well, who's your treatment buddy? She says, my cousin. So I'm trying to work out what's going on. So I said, tell me something. How old is your cousin? She says, 7. So, okay. So yes, they can choose their treatment buddy, but okay, it's got within reason, right? A 7-year-old is not reliable as a treatment buddy. It's true. This is true. Okay. So, yeah, they choose a treatment buddy. It can be a parent, it can be an older sibling, it can be an aunt or uncle, someone they trust, someone who lives with them, who can do the treatment together with them. And then the role of the treatment buddy is to watch them swallow. Okay, watch them swallow, because teenagers are the world champions at finding places to put their medication. I've had kids, not only personal patients, but people have told me about, who put the treatment in cracks in the wall, the toilet, of course, under the bed, under the pillows. One child in hospital was putting the tablets under her legs until the nurse came to make the bed and discovered all these tablets under her legs. The best I've heard is a child from the Northern Cape comes to the clinic with his little brother, and they said, "How's it going?" He said, "Fine." He said, "Are you taking treatment?" He said, "Yes." And little brother says, They say, "What do you mean, Butti?" He says, "Oh, he goes like this. He takes the tablet and he puts it in his hand, puts it over his mouth, slides it behind his back. The little Butti comes and takes it out of his hand and throws it away for him." It's like real teamwork. The only problem, he made a mistake. He brought his brother to the clinic. So that was his big mistake. So that's how the mistake came out. So they will find ways of taking the treatment out of their mouth or not putting it in their mouth and throwing it away. So what you need to, thanks for all the responses there. What you need to do is explain to the adult that their role is just to watch them swallow. Okay. It's just to watch them swallow. Sorry, there's an owl calling outside my window. So just to watch them swallow. So because they're not going to do it. Now, the important thing about watching them swallow is that, and also in terms of not disempowering them, you don't want to treat them like a baby. You know, little baby, here's your medicine, swallow. No, that's not what you do. So I tell the treatment buddies, parent, or whatever it is, what they need to do is they must leave as much as possible up to the child. The child or the teenager themselves must remember. They must get the medication and they must just come to the adult and say, "Here we go, watch me swallow." Put it in, watch them swallow, and that's it. And the adult gets told that if the child hasn't come to them to watch them swallow, they haven't taken the treatment. It's as simple as that. Like, you know, in nursing, we've got this maxim: it's not written, it's not done. Well, same thing. If it's not observed, it's not done. Okay. Take a time like 9 o'clock at night or whatever it is, they can choose down. If by then the child hasn't come to them to watch them swallow, they go to them gently and say, "Whoops, I think we might have forgotten our treatment tonight. Let's do it together." So there's two things. The child must do as much as possible. Child must remember, the child must do it, but just in front of the adult. And number two, very important, no nagging. All right? Children, teenagers, adults hate nagging. Okay? And the worst thing you do is nag, you know, it's 7 o'clock, take your medicine. It's 10 past 7, take your medicine. It's 20 past 7, you must win. You don't say a word. They don't say a word until that set time they've decided. The child hasn't come to them by then they will go and watch them swallow. And that works very well from that point of view. How do you get buy-in from the kids? So this is something I've developed over the years, and it seems to work pretty well. Okay, somebody asked, what is adherence? In the old days, they would call adherence compliance. Okay, we don't call it compliance because it's not politically correct. Okay, it suggests a negative trait. It's just, are the patients taking their treatment or not, in simple terms? Okay, so how do I get buy-in? So I'll say to the teenager, tell me something. Are you interested in any sport? Do you play any sport? Do you watch any sport? Hopefully they'll say yes. If they say no, so have had in the once or twice, then I'll say, well, does your dad watch any sport? Okay, so let's say they'll say they watch soccer. Right, so I'll say, okay, fine. So who's your team? All right, now I don't know who this team is, doesn't matter. This soccer funnies out there will tell us. Right, so let's say, they say, I'm from Gauteng, Kaizer Chiefs is my team. Okay, right. I'm not saying it's my team, it's the child's team. Right, so if they are going to, so then I say, fine, can you imagine the Kaizer Chiefs team, they're about to run onto the field. And as they're about to run onto the field, the coach says to them, "Bye guys, see you later." I say, "What do you mean, coach? Where are you going?" He says, "No, I'm going to the pub for a drink." But now the child is horrified, just like Lesejo is, right? He's horrified. He says, how can the coach go for a drink? So I said, well, who's playing the match, the coach or the team? He says, the team. So I said, fine, the coach is thirsty, let him go for a drink. said, no, you can't. They won't play so well. I said, so you mean even though the coach is not playing the match, the team won't play as well if the coach is not there? They say, yeah. I say, well, that's exactly what happened. When you take your medicine, you are playing the match of your life. Okay? If you score a goal, if you take your medicine, who's that a goal for? They're all saying for me. And if you throw it in the dustbin, who's that a goal for? Well, I get different versions, but they get it right? Some will say the death team, some say the virus. They will work it out. Okay. So when you're playing this match of your life, your treatment buddy, whoever it is your coach. And just like when your team goes to play, the coach has to be there to make sure that you score properly, you play properly, and you score for the right team. So must your coach be there and make sure that you score for the right team. If you swallow it, it's a goal for you. You throw it away, it's a goal for the other side. Okay. And they buy into that very, very nicely. Okay, they feel, and it's also buys into our concept of treating HIV is a team effort. And I say to them, look, we're a whole team. We all work together. This is you're the player. Your treatment buddy, whoever it is your coach. I'm the manager. You know what I'm saying? Whoever it is, we're all part of your team. So it buys in very nicely to our concept of the team approach. And they're quite happy with that. I have on occasion, like I had one child who's in third line. I said to him, you've got nothing left after this. You're on third line. I said to him, have you ever, what would you do? I said, if you were going into shark infested waters, I said, would you go alone or would you go with somebody else? I said, no, I'd definitely go with somebody else. So I said to him, it's not good enough for you to go and sit with somebody else. You need a shark cage because you've got nothing left after this. All right. And he appreciated that as well. Said, you're literally swimming with the sharks because if you don't get this right, you're not going to listen. He's now, I think, 28. He's suppressed on third line, doing very well. He's been on for many, many, many years. Okay. Right. So that's what seems to work best with adolescents in terms of adherence, getting a treatment buddy who needs to watch them swallow. For sure, it doesn't work in every case. Nothing is infallible. I will talk later about there are some kids where no matter what you do, you get the defiant teenagers where you really struggle. Yeah, okay, that does happen. But for the vast majority of teens, this works beautifully, especially if you get buy-in from them. But you're noticing that this takes time, okay? Dealing with teenagers takes time. You've got to build up a relationship, years, okay? Which is not so easy when they walk in for the first time as an adolescent. But you also, when you're talking to them, it does take time. Okay, I see there's a question about, can we give Olivia once daily with no issues? We can. It's not in the guidelines. But if you've got a patient who's struggling with the second line Olivia regimen twice a day, and they say, look, I can't do mornings, I've had no issues putting them training them to once a day, and they tolerate it very well. Look, Adazanova is a proper once daily protease inhibitor. The problem is that most of the clinics I deal with, the hospitals have got Adazanova, the clinics don't. They've only got lopinavir, and so in that situation, we have to make do with it. And I've had no issues, certainly with teenagers and even with adult patients. I've had adult patients where the sisters have phoned and they've said, what must we do? And I've said, well, change them to once daily Olivia. They're a bit incredulous. And I had one phone me back a few months later and say, look, I just want to phone tell you that patient is suppressed. So it does work. And if the problem is the adherence issues of twice daily, it will work. Obviously, if they're getting side effects from lopinavir, then making it once daily is not going to solve the problem. You need to change it to something else. Okay, disclosure goes a long way to help adherence. If the patient knows what's wrong with them, they're more likely to take the treatment. I will speak a little bit to disclosure. We have got a whole talk on disclosure. We've got a whole workshop on disclosure beside that. But I'll just mention disclosure can be complete, full disclosure where you're telling them the name, or partial disclosure where you're explaining what's going on without giving them the name. I'll talk about it in more detail later. Okay. All right. Let's talk a little bit about drug formulations. So you want to change to patients to tablets or capsules, not syrups. Look, adolescents, in terms of WHO, goes from 10 to 20. So I think I can talk about a 10-year-old. I came across recently a patient in private, a 10-year-old patient who's on lopinavir solution. 10-year-old on lopinavir solution. I tried to get them to change to tablets. I got told by the GP, it's not broken, why must we fix it? Because the viral load is suppressed. Okay. And that's the equivalent of, I don't know if you remember in the old days, we used to have these old cell phones, tiny little ones. But if you wanted to send an SMS to anybody, you couldn't just type like we do today. You had to press the A key 3 times and the T key 2 times. And you remember those phones. Also, the only game you had on them was Snake. You remember Snake? Okay, right. What was wrong with that phone? It was working. Why aren't we using those phones today? Because we've moved on. We've got far better stuff. It's the same thing. That medication does work in a situation where the child can't swallow tablets, but there are so many other better options. They could change to lopinavir tablets, no problem. There are other drugs as well we could give as well. So you don't want to, they all think it's because it's a child they need syrups. No, you can give a 3-year-old tablet. You can teach a 3-year-old to swallow tablets. Okay, and often it's better than the lopinavir solution, which tastes quite bad. Okay, but the other formulations we can just talk a bit about. The fixed dose combinations, the back of a 3TC, very useful. We've also now got this is obviously not for this age group, we're talking about a back of a 3TC combination for the younger children, dispersible. Tenofovir FTC is very useful. TEE and then TLD as well. Remember, from 25 kilos, you can give the efavirenz 400. From 40 kilos, you can give 600. That is probably going to change in the new guidelines, because there's adult data that you can give 400 milligrams. There's no pediatric or adolescent data, and that's why we've been holding back. But I think it's just going to happen. They'll either go into TEE in the new guidelines. They don't get TEE and they want to get the efavirenz separately. It'll be 400 milligrams, and you won't switch at 40 kilos. Rilpivirine is a very useful drug, especially patients who are not tolerating efavirenz regimens. You can use it from 12 years and 35 kilos. And there's also a fixed dose combination of tenofovir FTC and rilpivirine, which you also use from 12 years and 35 kilos. TLD at the moment is from 10 years and 35 kilos. Watch the space, because probably in the new guidelines, that's going to drop down to 30 kilos. There's not much data. There's really only there's mathematical modeling to use it in the between 30 and 35, and that's why in our guidelines we didn't do that. But there's been extensive experience throughout Africa with everybody, because WHO, everybody's been using it from 10 years, and so I think based on that is going to change in our new guidelines. Okay, so let's give an example. How would you simplify the regimen with the patient failing the second line regimen? So they're failing the regimen. Okay, they're on AZT3TC and lopinavir. It's twice a day because of the AZT3TC. Lopinavir probably still twice a day, but as we said, it could be given once daily. So that AZT is locking into twice daily. So you want to change it. So you can go to either back of a 3TC or tenofovir FTC plus lopinavir once daily, or you could use atazanamide once daily. So, and people, I think it's old news by now that with a protease inhibitor, you don't have to worry too much about the NRTI backbone. Even if they're resistant, you can use them. No problem. So rather change to a simple regimen they're going to take once daily rather than a twice daily regimen, even though on paper it may be more active, but if you don't take an active drug, it's not going to work. Okay. If they're less than 2 years in the regimen, it looks like in the new guidelines, you'll be able to even change them to TLD, because they won't have less than 2 years, they won't have PR resistance. And so then if they fail the TLD, you at least will have a PR regimen. You can go back to the lopinavir regimen as well. So that's probably going to be in the new guidelines as well. Patients on the back of a 3TC and lopinavir, well, often the back of a 3TC is once daily, but the lopinavir is twice daily. You can change that to once daily, lopinavir, or you could use atazanamide. And even if they're failing, if they've only ever been on the back of a 3TC, you can give TLD. Now, this is in the old guidelines, in the 2019 guidelines. We've obviously got the Nadia study showing that with TEE you can give TLD, but this is even going back before that. You can give TLD in that situation. Okay, when can we change to TLD? So this is changing, but I'll just touch on a few points. Historically, it was only a first-line regimen. Now it's been used for second line and third line. It's become so mixed up. There's no first line, second line, third line anymore. It's like a whole TLD could be first line, second line, or third line. So patients failing a backup 3TC regimen, certainly in the old guidelines already could be changed to TLD, providing there were no other NRTIs previously, and even that I'm not so sure today. Patients who are failing or on a second line regimen, backup with 3TC loperamide, after first line of backup with 3TC favirenz, where you've still only been on a backup with 3TC, no problem with TLD there. And patients who are suppressed on the PI regimen could change according to the Clinician Society guidance, which was issued in May this year. There are other changes which will come out in the new guidelines, but certainly that what I've discussed here, that's fairly solid, and we don't need the new guidelines for that. Okay. If there are any other cases, you would always discuss with the next. Right, let's spend a little bit of time talking about disclosure. So this, okay, let's just do a poll quickly. Very easy poll. Yes, no, yes or no. Have you ever disclosed to a child or an adolescent with HIV? Okay, this is very, very gratifying. And thank you for being honest. We obviously, it's confidential. We don't know who's answering what, but let's end it there. All right, very interesting. Right, approximately half, 54 to 46.
Yep.
So more people have disclosed than haven't. So that's really good. Okay, that's good. Okay, so remember, disclosure, it's a process, not a once-off event. When you actually finally disclose, depends on the maturity of the child, not necessarily the age. What I normally do is I would ask them, how they're doing at school. And if they are doing well at school, then between 10 and 12 is an appropriate age to do full disclosure. So if they haven't failed a year, they're keeping up with the class, ask what grade they're in, if it's an age-appropriate grade. Then between 10 and 12 usually works for full disclosure, giving them the name. But partial disclosure, you can do it much earlier. I usually prefer to start about 6 years for partial disclosure. Parents are often very resistant because they're worried about guilt, about the child being angry with them for giving them HIV, and also worries about the child disclosing indiscriminately. So the first one, in terms of the anger, for sure it can happen, but I must say, if it's done properly, you can minimize that anger. If there's a lot of explanation is done in a correct way, I don't see much anger. I have had one or two children who later on exhibited some anger and needed therapy, but generally, if it's done properly, we don't see that. And worried about the child disclosing indiscriminately, well, it depends what age. If you tell a 3-year-old they've got HIV, which some people do, then you're asking for trouble, because a 3-year-old doesn't know what HIV is. So his friend says, oh, I've got a sore toe. So the one says, so what? I've got HIV. Doesn't know what it means. Okay. So of course they're going to tell their friends. But if they know what HIV means, if you disclose at the right age, you won't have that issue. Non-disclosing creates barriers to communication. We see that in oncology, for example. The parents are sitting there with a child. The clinician is telling them, well, what's wrong, and they're talking hushed tones. And even though the child no one has told the child anything, they can see something is wrong. Okay, and they say to them, what's wrong? And they say, no, nothing, you're all fine. Okay. So what happens is the child says, well, parents don't talk to me, so I don't talk to them. And you get a barrier to communication. And as soon as you disclose, you break down that barrier. It's an amazing thing, because now they can talk. The parents are scared to even go near the topic because they're scared the child might ask more questions. And so you're going to end up then, obviously, with them being forced to say something. So you need to, disclosure is fantastic from that point of view. You don't want to lie to a child. I've heard parents tell their children they've got asthma. Okay, not the end of the world. I've heard them tell them that they've got cancer. Why tell the child they've got something which is got sometimes a very poor prognosis when they've actually got a very good prognosis? You know what I'm saying? You don't want to lie to the patient. When do they need full disclosure? By the time they're sexually active. Before that, because obviously then the implications there in terms of safe sex and everything else, so they need to know what's wrong with them. But before that, you can do partial disclosure. Parents are quite happy with partial disclosure. I always get consent for disclosure, even partial disclosure, but partial disclosure is not an issue. I've never had a parent who's had any issues with partial disclosure. There are some books and audiovisual material. We have a flip chart, which we developed based on my technique that I developed over many, many years. And I'm quite honored to say that the Department of Health is actually going to take over our flip chart and use that as the standard disclosure tool. So it's a big honor for us at Right to Care. And but there are other materials as well that are out there. Okay, so somebody asked about how do you deal with adolescents not in partial disclosure? Will you do partial disclosure? It's very quick and easy. You just need to get consent. You can get telephonic consent, and you can do partial disclosure very, very easy. Okay, so partial disclosure, ideally we should be involved. You want to picture the child's level with language they understand. I never use the term CD4 count, because first of all, it's a technical term, they don't understand it. And second of all, it does have HIV implications. I see one of the other methods, they talk about CD4 counts. Problem is they're talking about CD4 counts on TV with HIV connection. So I wouldn't use the word CD4 count. And I would rather say white cell count. We talk about germs rather than bacteria. And with time, you add to the story. Okay. And then also remember, children either forget consciously or unconsciously, right? So I always make a note, how far did we get? What did I discuss? Not just one word, all right, soldiers, or whatever it is that we've discussed with them. And then next time you test them, say, what did we discuss last time? Because they'll always say, I don't know. Either they're blocking it out psychologically or they actually have forgotten. So this is an example of how I do partial disclosure. So I'll say, then tell me about blood. What color is blood? I usually get it right. I had one little girl who told me green. Okay, I don't know where she was from, but she told me green. And I say, fine, blood is red. What color? I don't show the slide yet. What color are the cells in blood? And they'll work it out. And then I'll say, what other color do we get? And I always point to my collar, always make sure we're white. And I say, white cells, right? So tell me about the white cells. What do the white cells do? So you get red cells and white cells. Don't always talk about the platelets. Okay, what do the white cells do? The white cells are the soldiers of the blood. They go around your blood looking for germs. What's a germ? They all know what germs are, okay? They think they're dirty things that make you sick. For our purposes, that's good enough, right? They go around. What do they do when they find a germ? I always ask the child before I let them push the button. So I say, what is, if you've got a soldier there and they find a germ, what's a white cell going to do to the germ? And I always let them push the button and kill the soldier, kill the germ. I don't know what happened to the gunshot there. Didn't seem to work on Zoom. Okay. So yeah, so that's right. It kills the germs. And so if let's say you've got a sore throat, you've got germs in your tonsils, so the white cells in your blood will come out there, kill the germs there, and make you better. Okay. Now then I say, what happens if instead of having lots of soldiers in your blood, you've only got very, very few? And they'll all work it out. If you've got the right age child, they will work it out. If you haven't got enough soldiers, they'll all say you'll die. Okay. But that's okay. But before you die, what will happen? Okay. And then we'll say, fine, there'll be lots of soldiers, very few soldiers, get lots of germs, and then the person is going to get sick. Okay. And then, so say if you don't have enough soldiers, you're going to get sick. So then I will say that you were born with a problem where you didn't have enough soldiers in your body. You couldn't fight germs. And in the old days, they used to get sick. These days, of course, we're starting the treatment straight away, so they often weren't sick. But you didn't have enough soldiers in your body, couldn't fight the germs. And that's why you were getting sick, or that's why you started on treatment. But let's see how you're doing now. You should have more than 500 soldiers. Let's see how many soldiers you've got. I'll pick up their file. Wow, 1,300 soldiers. Big beaming smile. The mom pats him on the back. So I said to him, why have you got so many soldiers when you were born with so few? Because I'm taking my treatment. I say, exactly. And what's going to happen if you stop taking your treatment? They'll all work it out. They'll all say you'll die. Okay, they'll say you'll die. So no, we're not going to let you die, because as soon as the soldiers go down, we're going to change the treatment. So you won't die. Yes, you'll get sick. So now you have a child who knows exactly what's wrong with them, not a lie. They know what the consequence of them not taking the treatment, not a lie, okay? But they don't know the name of the virus. That's your partial disclosure. Okay. Full disclosure is a much more complicated. As I say, Nesecha, we can certainly organize a chat on disclosure if people want that. And the way we do it is we teach them all about HIV before you give them the diagnosis. Because once you mention that name, HIV, wow, it's like a ton of bricks has fallen on their head. Okay, you're not going to get any information into them, and they are traumatized. What you have to do is you have to educate them about their condition before you give them the name. And that's the method I developed. And that's, in fact, a flip chart that we use based on that method does the same thing. But we're happy to do that for another day. We don't have time now. Okay. Right. What about pill fatigue? So this is the definition I found in the Urban Dictionary: a condition occurring over time to chronically ill patients who take a lot of medication when they stop taking pills because of the stress and monotony of constant pill swallowing. I don't know if it's stress and monotony in our patients, our teenagers. I just think it's often another term. There's a nice Afrikaans name I'm not going to mention, where they've just had enough of taking pills. Okay, what are the causes? Well, there are many obstacles. Reasons for pill fatigue: too many pills, side effects, food restrictions, frequency of having to take the pills, time to take pills, cost is not a big issue, interfering with their life or lifestyle or job in a small percentage. Okay, things we would all imagine. Okay, and how do you deal with it? We've discussed these things. You rationalize, drop the non-essentials, fix dose combinations. If they've got side effects, change the drug. Food restrictions, change the offending agent. Frequency, go to once daily, or easy to work out. But what if you've done that and it's still not working? There's still got pill fatigue. So there may be a role for drug holidays. Now, we know from the SMART study like many years ago that long-term treatment interaction is not a great idea. Okay, you end up with CD4s dropping and they get sick. But a short term, about a month, probably doesn't cause any harm if it's done properly. And the way you do it, I don't want to go into too much detail, don't do it much anymore, but I have had patients who have really had enough, and we do offer them this if we're not going to win otherwise. You want to negotiate a good time to do it. You want to do it in conjunction with a healthcare worker. Don't just say stop the treatment. And what I'll say to them is, look, you've had enough of taking the tabs. How about we give you a holiday? Lovely. So would you? It's May now, right? When would you like to have your holiday? Now, in May, or in December when it's school holidays? December. I had one child who chose May because that was her birthday month, strangely enough. But most will choose December. I say, fine. Between now and December, you have to take your treatment every single day, and then we'll give you a holiday in December. So you're buying in and getting that extra adherence as part of this package, right? So it's dependent on good adherence the rest of the time. Otherwise, no holiday. Okay, if it's a PI regimen, you want to stop all the drugs simultaneously. The fixed dose combinations, you can stop the drugs simultaneously. The old non-nucleoside regimens, you need to stop the non-nucleoside first because it lasts long, you get a tail. Or you could swap to a PI regimen, or these days dolutegravir, about a month before stopping the treatment. But, fortunately, not too many people are on non-nucleosides anymore. Nevirapine also, if you interrupt for more than 7 days, you've got to go back to twice a day. But fortunately, we don't have nevirapine being used much. This is from one of my mentors overseas, Andy Pavia. He said to me a couple of years back, are you seeing widespread failure during adolescence? Your previously mature and well-controlled kids is exactly what happens. You think they're all fine, and then they just get a speed wobble. We try coaching if they ever feel they can't be consistent to call us. Perhaps we can do a drug holiday. Frequently, they develop major resistance before the truth comes out. So the thing about the drug holiday is that you want to do it before they're failing. They must be suppressed. It's not when they're failing. It's a patient who is well controlled to keep them controlled when they are experiencing pill fatigue. Depression. Okay, I think I've got a poll here. What percentage? Okay, I think we're running out of time, so let's forget that. Okay, there was a review of 8 studies looking at mental health in infected children and adolescents, and they found that depression occurred in 25% of patients. A quarter of our patients have got depression. I can tell you now, guaranteed, I'm missing a lot of depression because I'm not diagnosing depression in a quarter of my patients. Especially in teenagers, you have to ask pointed questions, okay, because they don't always present like typical depression. They don't always tell you they're feeling depressed. The other one, I'm sorry, there's something wrong with the animations, but it doesn't matter, which is very important to ask about, is ADHD. All right, ADHD also in children with HIV and adolescents, also approximately 28% of our patients will have ADHD, much higher than the norm, 6-fold increased risk ratio of having ADHD. Okay, and obviously there are many implications of ADHD because, well, first of all, going to depression, of course, major implication for adherence, because the child is depressed, they're not going to want, who wants to take medicine when you don't want to live, right? Same with ADHD, when the child is all over the show, they're going to forget their doses, it's going to impact on adherence, impact on disclosure, because they're going to blurt out they've got HIV without thinking about it. Okay, often it's associated with depression and poor self-image, but it's also easily managed. Big problem we have with ADHD in our clinics, the clinics are unable to manage ADHD, they've got to refer them to hospitals, so the HIV treatment they can get at the clinic, but they've got to go to the hospital for ADHD management. But it's worthwhile from a holistic point of view. You don't want to have an adolescent or child living to adulthood, all right, okay, but becoming a school dropout, because then you've lost the plot. You've got to look at the whole child. And the thing about school and behavior problems is that for some reason the parents do not think that is our responsibility. They will never, I've never had one parent tell me the child's struggling at school. You have to ask them that question. How are they doing? What grade are they in? Have they failed any grades? And then unfortunately all the truth comes out. But if you don't ask those questions, we can't really treat these patients properly. Substance abuse, we are seeing it. It's increasingly become a problem. Obviously impacts on adherence, impacts on relationships, and very often is precipitated by undisclosed ADHD. So you want to ask that question, you know, not only are they drugging, but is there something we could do to treat the problem which was causing them to drug as well? Okay, what about treatment failure? So although we're talking about adherence, but let's talk a bit about treatment failure as well. So what Homer Simpson is saying is very important. This is trying is the first step towards failure. Okay. And if you don't try, you will never fail. Similarly, we could extrapolate that to ARVs. Okay, I can guarantee you a way that a patient will never fail their regimen. Guaranteed, guaranteed. If you want a patient to never fail, you never give them ARVs. Guaranteed. If they never take ARVs, they will never fail their ARVs. So what Homer Simpson is telling us is that failure is part of ARVs. If you're going to use ARVs, you must expect failure. You must embrace it. You must deal with it. Just like you would deal with side effects, you will deal with treatment failure. You don't have to have a different expression on your face when they're failing compared to when they've got side effects. It's just part of treatment, and you just deal with like you would dealing with a patient who's got a side effect. Okay, it's almost inevitable in teenagers if they're not watched. Prevented by watching them swallow. If it happens, you don't blame the child. You never shout at the child. You never shout at anybody. Believe you me, I'm a converted shouter. I used to shout. I found it is counterproductive. What you do is you destroy your relationship. So now you need, okay, new relationship and new regimen. Whereas if you just smile at them and say, don't worry, it's not a problem. It happens to a lot of kids your age. Let's deal with it. No, you just need a new regimen. Much easier. So don't shout with the child. You just say, don't stress. I was expecting this. Many kids your age have it. Let's just deal with it. Chances are much higher if you keep your relationship with the child. Don't shout at the child. Okay, in terms of second-line regimen in our adolescents, some of this is going to change our new guidelines, but up to now, our national guidelines are good on paper. They don't always work for adolescents. You want this twice daily, this AZT 3TC lopinavir. Lopinavir you can give once daily, but the AZT 3TC, to me, it's just kills the regimen. Okay, because it's just not going to work. And we see this all the time. And that's why very often I would change them to a once daily combination of maybe tenofovir, FTC, and lopinavir once daily, or atazanavir once daily, or a backup of 3TC going back to the resistant one, doesn't matter, but to go for once daily. The Nadia trial we know is showing that you can use TLD after failing TE, so that's great. Instead of going for AZT 3TC, dolutegravir as a second line, you can go to TLT, which is 1 tablet a day. Going to make a big difference in our new guidelines. Discuss with an expert because there are ways of simplifying our second line regimens so they don't end up failing. And the new guidelines are certainly going to be helpful in this regard. Dots, okay, can you do dots, especially our teenagers? You want to change it to once daily regimen, but we discussed earlier, there's lots of drugs that can give once daily. You can put together a nice once daily regimen, and then you've got to think out the box, find a way of getting them to someone to watch them swallow the treatment. I had one child, I went to a clinic that said, he's not here today, he's at school, but you see this house next door? Yeah, that's where he lives. I said, okay, and what have you done with him? Oh, we sent him to the big hospital 10 kilometers away. So I said, bring him back. He's literally next door, literally next door. On your way home from work, somebody just pops in there, pops his treatment in his mouth, or watches him swallow. Think out the box, find a way of doing dots. Okay, sexuality, very important thing. I was told that teenagers will not talk to somebody who's older than them with gray in their beard, like I've got. That's why I dye my beard gray. Continue now, it doesn't work. They talk to me. Don't ask me why. They tell me the most intricate details. Okay, but if you feel uncomfortable talking to them about sex, find someone at your clinic that does feel comfortable and they can talk to them, because you do need to talk to them about it. Okay, and you don't want to be in a situation where she says, today I'll be explaining where your babies came from. It's a little bit too late at that situation. Okay, having HIV, especially from birth, can affect sexuality. They often have an impaired body image. They may have, in the old days, they had lipodystrophy. They're often short. It's definitely low. It gives you lower self-esteem. Delayed puberty can also have problems, threaten sexual intimacy, big problems, transmission issues. Because you is changing all of that, but they're still scared they're going to pass it on. And disclosure. I mean, we spoke about disclosure to a child, but how does that teenager now disclose to another teenager, to their partner? Very difficult, very difficult. And we should get involved. I do. I say to them, look, you can't tell a partner, hi, I'm Leon. On the first date, I've got HIV. Okay, they're going to say, bye, Leon. Okay, but when you get to the point when you are comfortable and you want to tell them, it's good to involve a third person. They'll take it better from a third person. Often my kids have got the files this thick. I've got one or two here. I can show you files this thick, and I say, look how thick the file is. He's a good boy or a good girl. He didn't do anything wrong. He's had it since a baby. And I'll explain all of that. I'll explain you cause you. I'll explain what the viral load is. And that helps them a lot if you can get involved from that point of view. Okay, there's often a lot of anxiety regarding sexuality, sexual relationships, and reproductive and sexual function. And often you have to explain all these things to these teens. And we need to discuss anatomy and function. Contraception, very, very important. Teach facts about transmission, safe and responsible sex. U equals U is a great one. It's also a good way of getting them to take the treatment if they can suppress their viral load. I had a patient today whose viral load has gone up to 290. And she said to me, is this going to affect my passing it on? And I said, yes, it is, unfortunately. So we discussed that issue. But she was aware of this because I've discussed U equals U with her. Okay. Sexual identity. I've had kids who are gay or bisexual, one wanted a sex change as well. So these are issues that, like, just in the normal population, we have the same issues with our adolescent HIV population. So adolescent groups are a great way of helping our adolescents to take the treatment and everything else. Teens will only communicate with other teens. Someone asked about peer educators using adolescents. For sure, it's a great thing to do as well. There's a lot of peer pressure out there, but if you can have peer pressure in a group where you've got a whole group of everyone's got a suppressed viral load except one. Okay, that's the kind of peer pressure we want, to get that person to suppress their viral load. Peer counselors are a great thing. They've been shown to help. Very, very important. I see someone had a question about that. They've all got similar anxieties, fears, or questions. For example, sexuality, prognosis, childbearing, disclosure, transitioning to adult clinics. So it makes sense to discuss these topics together as a group with their peers, where they can discuss with people that they're comfortable talking to. And you need to have a responsible person that teens trust, and you can have an older teen themselves, as we discussed, who can do this with adult supervision, depending on the age of that teen. And there's a set program of topics for discussion. We've also developed a flip chart that people can use to help them to run adolescent groups. Very, very useful thing to do. Often we find our clinics, you get someone who's very keen, gets going, and then a few months later they get rotated out because the clinics have this policy of not letting people become too expert in a certain field, so they moved out, and then it just collapses and you've got to start from scratch again. But it's a very important thing to do. In terms of transition to adult clinics, so I think certainly in the DOH is not as big a problem, because often it's a one-stop shop. The whole family comes in and there's no transitioning. So that's much better. But if you have a dedicated pediatric clinic, then it is a problem. And I'm not sure who's more traumatic, for the caregivers or the patients. You know, I'm scared to send my patients to other people. Fortunately, they don't want to leave either. So I had a 22-year-old today who said to me, I said to her, no, it's 25-year-old. She said, I turned 25 last week. So I said, well, you know, aren't you embarrassed coming to a teenager? Aren't you embarrassed coming to a pediatrician? So she said, no, I wouldn't dare leave. So, you know, what can I do? But in my situation, I can continue seeing them with a few little provisos. I send them off to gynaes and things like that. But you know, if you're at a state hospital, you can't keep them to me what their age is, 12 or 15, whatever it is. So you need, you know, we're scared, they're scared. We fear that the new caregivers won't be able to manage the patient. Patients are scared about the unknown. They've grown up with this person. They don't want to go somewhere else. So sometimes it's easier in our family-based clinics where there's no transitioning, but the important thing is communication between the parent, the old clinic, and the new clinic. Even if it means someone from the old clinic going with them for the first visit, or someone from the new clinic coming to the old clinic to meet them so that they've got a familiar face. There are things that you can do to ease the transition, making sure that the new clinic knows exactly all about this patient, and giving you a little back door to say, look, if you're really stuck, come back and we will try and smooth out all the lumps. Okay, there are some really difficult patients. There's no question. Okay, what I've told you about works for the vast majority. There are some kids who really, whatever you do, you end up with not working. Kids who know the diagnosis, just rebel and stop taking the ARVs. It happens. Fortunately, not often, but as my patients have matured, I am seeing it. And it's just one of those things. The important thing about this is that you do what you can, but the most important thing is that you need to let them know that your clinic or your consulting rooms or whatever it is a place of love. It's a place of acceptance and understanding. And when they are ready, they are welcome to come back. If you get angry with them, you're going to close those doors. And you want the doors to be open so that when they are ready, they will come back. And I've seen it. They will come back. Okay. Patients ran away, whatever, stopped taking the treatment. And now they said they're ready to start treatment again. And that's fine. Don't close the doors. Make sure that the clinic remains a place of love. So we don't shout at our patients, even if they're not taking the treatment and they're not really in there, they're just in a position. Often they are depressed. Treat their depression, treat the ADHD, treat whatever it takes if they'll let you treat them. But make sure that they know that you are loving them, and you want, when they come back, you will accept them without shouting. Otherwise, they won't come back. I get this. Adolescent patients who just can't or won't swallow tablets. I've got two brothers, okay? They're both on third line. One's on TLD and the one's on darunavir, ritonavir, and TLD. They can't swallow big tablets. They're on individual. They're on 6 tablets a day. Contrary to whatever I've been teaching you this whole hour, right? But that's what they want. They're taking that. They're suppressed. So that's fine for them. I wouldn't recommend we do that every patient, but for them, we do that. I had an 18-year-old had to put on syrups. Okay, and she eventually got over the issues, and then we went back onto tablets. But Work with the patients, work with whatever works for them. And don't say, well, you're a big child, you should be able to swallow tablets. It doesn't always work. I've had the patient with the best intentions and really wanted, but often no support, you just can't take the tablets. I've had a patient I used to WhatsApp her every Sunday. Literally every Sunday I used to it's on my computer. WhatsApp so-and-so. It's WhatsApp. How's it going? Did you manage to take it to me last week? Okay, keep it up. And I got her suppressed. We have to accept that we will not win every battle. There will be some teens where we will struggle with it. Okay, that's life. But the things I've told you about now are things that for me have worked in getting these children to take their treatment. It's not, I haven't covered every topic that's out there, and people will, I'm sure, will pick me out for that, but that's fine. These are practical things which I've found which work for these teenagers. But there are some ways where I haven't had success, but I'm keeping the door open by, I've got a file of three patients I've got to contact now. Patients who've stopped taking the treatment, just to let them know I'm out there. When they're ready, will accept them back with loving arms. It's very important that they get that message. As I said, important for our clinical rooms to be a safe haven for them to come back. So when they eventually decide to come back, they will come back. We don't close those doors. Okay, so this happens. They eventually get there, where they start taking the treatment on their own without any problems, all by myself. And it's a wonderful thing to see. In my experience, between 6 and 25 years, you can't predict when it's going to happen. Some patients, 16-year-olds, are vehemently anti. Some 16-year-olds are taking the treatment on their own already. It just happens. It's an amazing thing to see when it does happen. And you just have to go through the motions until it happens. So to summarize, and I'm sure I've gone a little bit over time, adolescence is a challenging time for everyone, the teen, the parents, the doctor, and the nurse. And all the more so if you have had any chronic disease, especially HIV today. Teens break many rules. Sometimes we have to bend the rules slightly to deal with them. Not quite the guideline regimen, but to give something that they're going to take, that they will take. But it can be very rewarding. They get right. But remember, you only consider you've had success when they get to the age of 30, because adolescence literally goes up to 25 years of age. Okay, just want to acknowledge Dr. Rana Chakraborty, who gave me permission to use a lot of his slides. There are very few of his slides left. I've added much more of my own slides to this, but certainly this was the start of this presentation. Okay, and if people would like to contact us, this is the Right to Care helplines. You're welcome to give us a call. The HIV helpline or the TB helpline. I'm more involved in the HIV helpline. You're welcome to give us a call, and we can try and help you. We can't help you with every single situation, but we often know who will be able to help you, and we can refer you to that person. Okay, thank you for that. I'm sorry.
Thank you. Thank you, Dr. Leon. That was quite empowering. You have covered quite a significant number of issues that we deal with, on a day-by-day basis. I see there's a national manager for the CCMT program, Ms. Letta Seshoka. I'm not sure if, Letta, can I put you on spot just to make a comment from a national perspective, and then we will go through some of the questions. I'm not sure if I'm putting you, if you're in a suitable environment. Letta? Are you there? All right, I think, try to unmute. Hi. Oh, yes, she's there. Yes, Ms. Letta.
Hi, colleagues, can you hear me?
Yes, well.
Okay, yeah, just to say what a informative presentation, and that will really make our patient to adhere fully on treatment, even our teens. I'm happy that Adolescents is on board in terms of strengthening the adherence support. But I think the key challenge that we are still having is the disclosure that is still not working well, because if patients didn't, especially the teens, didn't disclose, how do you start by talking about that here?
Right.
But I think it's work in progress. That will help a lot in terms of what Dr. Leon has presented. I'll end here. Over and out.
Thank you so much.
Thank you for that comment.
If I could just comment, thank you, Letta, for that. Yes, and I think disclosure is a big thing. The problem is that we as clinicians are scared of disclosing. That's the biggest problem. So we lump it on the poor old parent, who's even more scared than us because they know nothing about HIV. they've got all this guilt, and we're expecting them to do it, and it just doesn't work. We need to be empowered to do it and help the patient. If the parents want to do it, the whole thing, with pleasure, we'll help them to do it. If they want to do nothing, with pleasure, we will do it all ourselves. If they want to do a bit of each, we do some, they do some, that's fine. Work with them, but we need to do that, and we need to get people the skills. I think it's a great move that the Department of Health is going to be using our flip chart, because it's really, I don't know, because I developed it, but it works. It's unbelievable. I don't know how I got it right, but it works unbelievably. It's so predictable. It works so well, and it's a very, very easy method to use. So that's great. That that people, there were issues with the previous one, but I think this will solve those problems. And also, Lesego, maybe we should schedule a workshop on disclosure. With Dr. Julia as well. She's got a lovely talk, and then we can, we normally do a 2-hour workshop where we do discussion on it, and then we do a little role plays as well, just to show how we do it.
Cool.
But we can certainly do something like that.
Yes, and there was a question about the chart, Leon, from other people here to say, is it something you are willing to share? I think it's Lydia at 7 o'clock.
You normally send out all these materials afterwards.
Yes,
so I will send you. It's a massive file. Unfortunately, the printers gave it to us. It's like 11 megs or something. So I'll give you the link, and then you can send the link out, and people can just download it.
Okay, superb.
But it is being updated, and hopefully we'll get the updated version soon, and it will be available in all DRH facilities.
Yes. And Leon, do you often get a question where a young person asks you, am I going to die? And what is the best way to respond to that question? Okay,
so I mean, the most important thing about that is that you need to avoid them asking that question by giving them information long before they get to that situation. In other words, when you're just doing your disclosure, the way we do the disclosure is to explain to them all about HIV, all the fact they can live a normal life like everybody else, okay, before you actually tell them you've got HIV. Okay, but if they do ask that question, are you going to die? We'll say, look, everybody dies, but we can tell you now that people with HIV who are on treatment will live as long as everybody else. In fact, there's 1 or 2 studies where they actually live longer. Okay, and the reason they live longer is because these are young people who would not be accessing healthcare facilities, so they're not getting their blood pressure checked, they're not being checked for diabetes, and all those kind of other things which are happening because they happen to be accessing healthcare facilities. So and pap smears in females. So people with HIV are often living longer because they're not for the HIV, but because of the other conditions which are being picked up, screened for, and so they're living longer. So it's just a question of explaining to them that they're not going to die. But the problem is they're out there, especially in the school system. The school system uses HIV to try and get the patients to be monogamous or to abstain, in fact. Okay, so they'll teach the kids that people with HIV will die, okay, and people who get HIV are people who are sleeping around. So the minute you tell this child he's got HIV, he immediately thinks he's going to die, and he thinks he's a bad person. And that's why in our method, what we do is we teach them, we correct what was taught to them, all the falsehoods that were taught to them, we correct that first before we tell them about HIV. Okay, and that works very, very well. Okay. Good. Any other questions?
Yes, I see a hand from Futi. Futi, you may unmute, and then I'll have a follow-up question for you, Dr. Leon, which is about whether when you reduce the pill burden, does the viral load need to be suppressed?
It's a good question. So I think if I can answer that quickly, I think it depends on what regimen they're on. If you're staying within the protease, let's say you're going from lopinavir twice daily to once daily, or from lopinavir to atazanavir, you're staying within that class of drugs, or you're changing from AZT3TC lopinavir to tenofovir FTC lopinavir, then it doesn't have to be suppressed. You're staying within that class of drugs. Okay, but if you are changing they're failing, we've always taught don't change one drug in the failing regimen. So then you shouldn't change one drug. as you know, Lusejo, a lot of it is changing because of the Nadia study and the other study which we already discussed. So there may be situations where you can change one drug, okay, but it has to be to specific regimens. For example, they're failing TEE because of the side effects or just failing in whatever, you can go to TLD. But that's the new research, and the new guidelines are going to cover that. Okay, so it depends. It depends. It's just a short answer.
All right, Mosele, are you able to make your comment?
Yeah, thank you, Doc. Actually, it's not a comment. It's a bit of a concern, especially with your HIV positive teenagers. Like, they've been doing well on treatment throughout high school because there was parental support and everything. But post-matric, now they're in varsity, they now want to experimenting. And, like, I've never been that person that's really been boring with them. But, there's some things that I want to discourage on a mere technicality that, like, we cannot risk putting your organs at risk. But, I don't want to sound like the nerd they always call me. So I don't know if I can perhaps get a tip on how I can, discourage this illicit drug use and alcohol use that's happening in varsity, because they also want to have fun. They also want to do what their peers are doing. So, I mean, it's difficult to disclosing to their partners because now they're starting to date. Now they also want to do alcohol. And so I really find it difficult, like, without sounding like too much of a nerd.
No, 100%, 100%. You don't want to encourage them in their habits and what they're doing. But on the other hand, if you are too much of a nerd, they're not going to talk to you. So what my approach is, I say to them, look, my aim is to allow you to live a normal life. Okay, that is my aim. That you must be able to live a normal life, have a normal lifespan, to be able to get married, have children, not pass it on to your partners, not pass it on to your children, to be able to get a job, to do everything else that everyone else does. Okay, but when it comes to, and just like with everybody else in these situations, I'm not going to say that you don't experiment with drugs, don't experiment with alcohol, but the important thing here is certainly with in terms of alcohol, to do it in moderation. Okay, they always say to you, well, is there a problem with alcohol and HIV? Yes, I do believe there is. I've seen some studies where patients will get more rapid development of alcoholic liver disease, for example, if they're HIV positive. But as a general rule, okay, the most important thing is, in terms of alcohol, is that the patient is completely inebriated the whole weekend and forgets to take the treatment. So I don't discourage them to drink, but I say, look, you need to make sure if you're going to drink, then before you leave on a Saturday night, take your medicines before you go. Okay, but also, as you say, everything in moderation. You don't want, and certainly I don't encourage them to drug, but there are patients who drug. I've had a couple of patients. I saw a patient today who was in rehab. It's been in rehab and she's fine now. But that happens. It does happen, just like with every other child. You want to discourage it, but you don't want to be this complete nerd, because as you say, and say you're not allowed to drink at all because you don't have boyfriends and girlfriends. That the parents tell them, okay, you will not get a child to tell you they've got a boyfriend or girlfriend. Well, pre-COVID days, when I used to examine patients, I used to go into my examination room, and that's when I used to ask them if they've got a boyfriend or girlfriend, because I would never ask in front of the parents, because they all say no. But that's the culture, and that's what we have to deal with. And just to be aware of these things, be sensitive to these things, but also, saying, you can't be one of their mates, but on the other hand, you can't be too strict and disciplinarian, because they're not going to talk to you. So you have to be somewhere in between. But they need to know the clear boundaries, and the clear boundaries are, it's not acceptable to drug, alcohol within moderation, but it mustn't interfere with your studies. It must be after weekends, that kind of stuff, and mustn't interfere with your medication take. But it's not an easy.
Two more questions. One, maybe it will be Mamsi, but before that, Ganizan is asking, so, I mean, it's a health systems question. Should we go the center of excellence route, or you believe that it should be a service that should be offered in every single health facility in the country? What's your...
we can't, certainly with teenagers, we can't send them all to the centers of excellence. First of all, in terms of adherence, it doesn't work. I mean, some of the, like in the Free State, some of our patients, to get the center of excellence takes them 2 days, because they've got to sleep over and then travel, and it just doesn't work. And then, no one's going to take the treatment, and then they're not going to collect the treatment. I think we have to get it out there. Right, okay, we've got our helpline where people can phone us, and it's like having an expert sitting with you in the examination room. We try to do it with you while you're phoning with your patient. We're right there, and we can help you. Even if it means patients who need resistance testing, we'll guide you through the process. We'll send you the forms, whatever it is. They don't have to be sent to a center of excellence. And I think it does work. It really works. I mean, we've got thousands of calls, annually on our helpline and from all over the country. And, they wouldn't be phone, and lots of repeat callers. It wouldn't be phoning again if it wasn't working. So I think it is working. And there are ways of doing it, of having an expert there with them in the clinic, that they don't have to send them all the way to the expert. Rather, get on the phone, and we'll phone you back. We'll do, as you can see there, you can send a please call me, or an SMS or WhatsApp or missed call. We'll phone back, and that's one way of getting an expert there with the patient, rather than send the patient all the way to the expert. I think it works.
Superb. Colleagues, the last question is from Mamsi. She's going to ask a question live. Mamsi Lokanyani, yeah.
Thank you so much, Doctor, for having me. Dr. Leon, we appreciate your insight on this topic. I work for the Adolescent Girls and Young Women and Adolescent Boys and Young Men NGO here in the Free State in Senegal. And most of the times now, my clients are writing exams, the grade 12 exams, and now they find it difficult to take their treatment during the camping, because here in Free State, a lot of children are at school now, are camping during their matric exams. So a lot of them are asking me, how are they going to take their treatment in the presence of other children? My strategy is that just take it out of your luggage bag and go outside and drink, because they're having a problem. I'm afraid I will have a lot of people who have defaulted at the end of the exams. Can you please advise on how I can tackle this? Thank you.
It's a brilliant question. It's a brilliant question. It's a kind of question where I don't think there's one answer. I think you need to look at every situation. I mean, what you can do is you can advise them, don't take the medication in their original bottles, because Dr. Google is everywhere. They can just Google the names. So put them into a bottle that doesn't have the name. If they're just going for a night or something, then put the tablets in a packet in a pocket, and they can just go into the toilet and just take it there like that. Otherwise, everyone carries a bottle of water these days. Carry your bottle of water with you. Go outside somewhere and take it. Go into the bathroom and take it. The problem is if the medication is not in front of you, you're not going to remember it. So so maybe set a reminder on your phone or something like that. There are ways of doing it. If you really are at a push, okay, if you really are at a push and they can't find a way, it's just not going to work. Explain to them it's safer to stop everything just for that short period of time than to take it and one day you take it, the next day you forget it. Rather say, it's just not going to work. You see, sometimes the kids will go home, either structured treatment interruptions that we discussed, or they go home to the rural areas in December and they're not going to take the treatment. It's safer then to say, stop your treatment before you leave, okay, and then don't take it at all, and then start taking it again when you come back. That would be an extreme measure, but it works. It's safe, and you're not getting resistance if you stop everything together. With the old non-nucleosides, it was an issue because it lasted longer, but certainly with our present regimens, that's not a major issue. They can stop everything and restart it as an extreme measure. Otherwise, try and find, like you say, ways of them taking it where it's not obvious what they're taking. There's no names there, and they can do it privately, and nobody's going to know what they're doing.
Superb. Dr. Leon, obviously we need to do that disclosure workshop, and just want to thank you once more for this great empowering session. I see people stayed way beyond the allocated time. It shows the importance of the topic we are discussing today. So we just want to appreciate you on that note. Any closing remarks, Dr. Leon, and then we close today's session.
Yeah, just to thank our sponsors, AbbVie, for all their support, which is really quite amazing, and to thank everybody who stayed over the time. I do apologize for going over time, and just to say that the adolescents, they are difficult, without a doubt. Do I enjoy them? Unbelievably. You get so much satisfaction when you finally get it right. It's an amazing thing. Okay, don't be despondent. Okay, you've got to try all these little tricks and phone us and we'll try and help you with them. But really, you can get there. There are very few patients who have had, literally I've got 3 patients and I've got to phone them, okay, who have really haven't achieved success with. But the vast majority of them, we get them there. But it's not easy. It's not easy. No one's kidding. We're not kidding. It's not easy. But don't be despondent. Don't say, it's an adolescent, it's not going to happen. Okay, it is going to happen, but you have to work hard at it. I'm not going to say it's easy. It's not easy, but it happens and it works.